thank you everyone for your kind and patient hearing.
Thank you. Thank you, sir. Now I request Dr. Veena Viswam, who is a consultant glaucoma and cataract surgeon at Amardeep Hospitals, to tell us about give us a case-based discussion and complications of glaucoma laser treatment. Dr. Veena.
Good afternoon, everyone. Thank you, madam. My presentation is on laser complications in glaucoma. My experience of lasers in glaucoma is peripheral iridotomy and selective laser trabeculoplasty. Peripheral iridotomy, most of you will be familiar with the common complications. Transient IOP rise is very common. I am not going to take a case and present it before you. So maybe because of AC bleeding or iritis, IOP hike is very common after PI. Then thick iris may need multiple shots. Spontaneous closure is common. Endothelial burns because the anterior chamber will be shallow. Endothelial burns may also occur. Hyphema is common because it is a photodisruptive laser. Anticoagulants, whether to stop or not, is your discretion. You may decide, depend upon the condition of the patient. Then what I do is I use an Abraham lens, 66 diopters, iridotomy lens, focus and separate and aim a little deeper into the iris trauma and give the shot, and I give a tamponade in case there is a bleeding. Then I choose also as everyone, I choose the iris crypts. Then lens capsule damage is common, cataract formation and posterior synecdoche at the site of PI. All these are commonly seen and usually often noticed after pupil dilation. Then if the PI is large, as in this case, this was a very resistant pupil, iris, and we had to give multiple shots. The PI was closing again and again, so the PI has come very large. So in such conditions, zonular damage may occur, and some cases of even sublane subluxation are also reported. CME may occur because of repeated laser applications. Then late complications like closure or peripheral anterior synecdoche, decreased endothelial cell counts again. Then pilocarpine use in long term may result in RD. All these are rare complications. Dysphotopsia, as you all know, if the superior area is chosen, I do not usually choose the superior area because it may interfere with the tear meniscus and may cause diplopia. Usually my preferred site is temporal PI, and I don't usually get dysphotopsia or diplopia in any of my patients. Then I am discussing three rare cases, important cases after PI and one after selective laser trabeculoplasty complications which I got. So this is case number 1. It was a 56-year-old lady who was a hypertensive, and her mother had history of glaucoma. Her visual acuity was 612 both eyes. She had a +1 diopter sphere with 6/6 vision in both eyes, IMSC both eyes. Anterior chamber depth was Van Herrick's 2. Schafer's grade 0 right eye, slit angle left eye. CDR was 0.6 and 0.4. IOP was 28 and 24. So laser PI was done in both eyes. Post PI day 1, IOP was 22 and 24 and 24 in right eye and 22 in left eye. We gave timolol and predfort as usual, but she came 1 week later with severe pain, vomiting and headache. As you all know, the vision complication I'll tell later. The vision had dropped to CF. And left eye vision was 612. She had circumcorneal congestion, cornea was hazy, AC was flat, pupil mid-dilated, periphery touching pupil, touching iris, PI was patent. So IOP was 60. So the most common suggestion is that of a malignant glaucoma. Okay, so we gave atropine, IV mannitol, timolol, dorzolamide and brimonidine and topical steroids. IOP came down to 26. But even after 1 week, the IOP is remaining 26, AC is still shallow, and we are planning a cataract extraction in that case. The case number 2 was a 52-year-old male, visual acuity 6/6 both eyes, anterior segment NS1, AC, Van Herrick's 2, Schafer's grade 0 to 1, CDR 0.8 in both eyes, but as you can see, the OCT is coming as normal. IOP was 50 in the right eye and 38 in the left eye. Laser PI was done in both eyes. He needed repeated shots. The picture which I showed earlier was that of the patient. He needed repeated shots. Every time we did it, it was closing, and he had severe iritis. 2 weeks later, but the IOP luckily came down to 16 in both eyes. IOP 1 month later was increasing to 26, and he developed a correctopia. Gonio showed peripheral anterior synechiae in both eyes. 2 quadrants were open, but it was becoming shallow. And lens thickness we did, and it was around 4.8 millimeters. So is it a combined mechanism, or is it because of my laser shots damaging his zonules? Is it coming forward, or is it because of the lens thickness? He is currently on anti-glaucoma medications. This is the anterior segment OCT of the patient. And because the vision is 6/6, we did not do a cataract surgery. We did not advise a cataract surgery in that patient, but still we are planning to go ahead with a cataract surgery in the recent future. Now the case number 3 was a 48-year-old female with family history of glaucoma, visual acuity 6/6 both eyes, AC Van Eyck 2, gonio, grade 1 Schaffers, CDR 0.7, IOP 26 right eye, 22 left eye, visual field normal, OCT normal, PACI 542 and 548, thick iris, repeated PI, non-patent PI, we repeated grade 3 cells and pigments. IOP was again 32 and 34, we treated with steroids. So every time we repeated the PI, we had to treat her with steroids. And 3 weeks post-laser, PI was patent, but IOP was remaining at 40. So though the cornea became clear, AC became deep, occasional cells were there, till steroids tapered, endothelial cells showed fine KPs because of the reaction. Again, sometimes the cells were coming, steroid were stepped up and reduced. Now this IOP after 6 months is still in the 30s, and we are putting her on anti-glaucoma medication. So steroid response, she might be a steroid responder. So that is another complication. When you repeatedly treat the patient after PI with steroids, the patient may go in for a, please check whether the IOP is coming up even after the PI is patent and AC has been quiet. Now, I have one more case. This is a usually we know that in selective laser trabeculoplasty, we are not doing any damage to the trabecular meshwork as such. Only the melanocytes are being treated, and complication rates are much lesser with selective laser trabeculoplasty. Now, I had a case like this. I would like to get the opinion of the experts as well. This was a 64-year-old male, one-eyed patient with history of bronchial asthma, allergy to brimonidine, visual acuity, right eye was hand movements, left eye 612, IMSC, pupil sluggish, RAPD in the left eye, CDR is 0.5 in the right eye, NRR normal in right eye, the eye with low vision, and in the left eye which had glaucoma, CDR is 0.9 and near total cupping. Right eye had retinal geographic atrophy, but disc was fairly normal. Left eye was the advanced glaucoma eye. So the right eye AOP is 17, left eye 20. He was already on travoprost and dorzolamide. He was allergic to ROCK inhibitors and not willing for trabeculectomy. So because the patient's IOP was remaining on the higher range and it was the field was advancing, we did not have any other option. So after discussing with experts, we thought of going in for a selective laser trabeculoplasty and trying it for the patient. And to our despair, the IOP increased to 26 after this. I even discussed this case with Ganesh sir in the last CME, I think. And according to him also, it is better to restrain from doing SLT in advanced glaucoma patients. But to our relief, after 8 months, the IOP is now 12 in the left eye. So how did it come down drastically after this? Is there a delayed response for SLT is something I would like to get an explanation from the experts as well. Thank you. That's my presentation. Thanks.
Thank you, Veena. Would you like to speak now, sir?
Yeah, delayed response is known. I mean, even for a primary SLT in a mild to moderate, you can get a response in about 4 to 5 months also. So you just handhold the patients for some time. And was the patient on medication at 8 months? He was still on medication? Not steroids for the SLT. Yes, that's understandable. But yeah, but the glaucoma medications were continued. So the same dorzolamide and travoprost was being continued. It was, now it's, yeah, so you could get a delayed response with SLT. So even the light trial, they have done good number of eyes with have advanced glaucoma. They have shown good results. Unfortunately, in that same proportion of patients, same group of patients, some of them have gone on to undergo surgery. So they do respond in advanced glaucoma, but we should, it's very difficult to predict who will respond and who will go in for surgery. So though no harm in doing it, provided we can buy some time and sensitize the patient that the need for surgery is there, and then go in for surgery at a later date, if necessary.